You can restart. Which is the hearing regarding Encompass Health Rehabilitation Hospital of Branford, docket number 25-3282-CON. You've taken care of the lion's share of the technical portion of today's hearing. As I understand it, we do have one additional person who wanted to offer public comment, so we're going to allow that at this time. Individual is in person and it's coming up front.
My name is Perry Maresca. I'm Economic and Business Development Manager for the town of Branford. Connecticut continues to have an increase in the need for inpatient care. Some are young people with sports injuries. Some are middle-aged people who are trying to stay young. Some are an aging population with increased medical needs. Major reason for the increase is the influx of people along the eastern shoreline. During COVID and post-COVID, used to be summer homes or weekend retreats in Branford, Guilford, Madison, Clinton, and beyond. Some permanent residence for those working in Fairfield County and Manhattan. Instead of living in Manhattan and running up the shoreline on weekends, they're living on the shoreline, working partially from home, commuting to Manhattan 3 or 4 days a week. There's nothing along the shoreline that provides what Encompass Health provide for the patients that need this service. It'll be 3 days, 3 weeks, 3 months, or more. People east of New Haven to New London able to receive the attention and medical rehabilitation close to home. I remember when I was young, my grandmother had a stroke. A 40-minute drive to see her while she was being treated as she underwent therapy. It's difficult for our family to drive out and see her on a regular basis. As you could imagine, it's very difficult for a child to never know when or if you would see your grandmother again. In this day and age, technology, the medical field has made tremendous accomplishments. Connecticut prides itself in what it offers to the state, the region, and the country as a whole. This desire to be forefront in medical research and technology, our state strives to give the best medical options and treatment possible. Encompass Health will add to that proud reputation. This facility that they're hoping to build just east of New Haven, over primarily the shoreline area. I respect and understand a business concern about competition. Interveners' concern about competition should not be at the expense of patients' needs. Heard from and or received letters of support from many doctors and political leaders from the area, all in support of this great project. Dr. Michael Lucchini, an orthopedic surgeon, clarify and address anyone's concerns. Dr. Lucchini, in fact, is retired. He did write a letter of support, and he had every intention of speaking today from his home in Florida. He had difficulty accessing the meeting while you were calling on the doctors to speak. The fact that he's retired should serve as even more impressive testimony. He's not supporting this for any personal gain or advantage. Instead, he is supporting this because through his years of experience, he often recognized the need for facilities such as this on the Connecticut shoreline. Advanced CT, Greater New Haven Chamber of Commerce, Lindy Lee Gold, who's the Connecticut Department of Economic Community Development. She actually had logged on since 2 p.m. scheduled to speak at 2:30, we lost her at 4. Lonnie Reed, she also is in support of the project, and she was scheduled to speak, and she had to change and go to another meeting. She couldn't stay any longer. Jim Cohen, Robin Comey, Josh Brooks, current First Selectman, spoke earlier today. Jamie Cosgrove, previous First Selectman of Branford. Matt Hoey, First Selectman of Town of Guilford, and Michael Frieda, First Selectman, Town of North Haven, are just some of the politicians that care for the communities around here have spoken or sent in favor of this. All organizations and politicians who have the Greater New Haven areas in mind, all have supported this project by sending in letters to the committee by volunteers to speak on behalf of the proposed facility. The need is clear. Facilities such as this adds to the goals and reputation of the state to continue to be recognized as a leader in the healthcare industry. Encompass Health brings additional care to the many in the state and this growing population of those drooping from advanced surgery. I'd like to close by thanking each of you for allowing this public hearing. I trust that you understand the need for such a facility along the shoreline, as expressed by many of the leaders and stakeholders in the area. There's a definite need and and a desire to have such a beneficial facility in this area. Branford, well as this location, ideal for this need.
I'm sorry, sir, what was your name?
Barry Maresca, Economic Development and Manager for the town of Branford.
So turn to OHS questions. As I mentioned earlier, I'm going to be asking the majority of them, but hopeful that Jackson and Viola will chip in where they can. It's usually around now, in this point of day where my brain starts to get a little bit slower. So I'll do my best to muddle through. Do have questions for both the applicant and the interveners. So best to stay engaged despite how late it is in the day. And in terms of questions to the witnesses, I will do my best to direct them to specific people, but to some extent, I may just be asking them and whoever feels best equipped to. So the first question I had, and this is probably directed most to Mr. Gooch, it's sort of like a general sort of organizational question that was related to a response that Encompass gave and their response to the completeness letter. So Encompass noted that it spun off from health and hospice business to a newly formed company called Abbott. Is there presently any connection between the two companies in terms of organizational structure, to your knowledge?
No, sir, there is not.
Is there any overlap in the governance or controlling body of the two companies that you're aware of?
Not to my knowledge, no.
And I wanted to ask that question up front because that sort of tied into a question I was going to ask later on, but I can cross that one off my list. So now we're going to shift focus a little bit and start talking about need and duplication of services. So a lot of these questions are probably going to be directed to Ms. Chafin. It's Chafin, right? Not Chapin.
Right.
So according to US News, they rank us third healthcare in terms of quality in the country. By us, I mean, not me specifically. So the application seems to argue that we have unmet need simply because we have fewer IRF discharges and higher SNF discharges. But since we're ranked third in the country by US News, doesn't that seem to imply that whatever substitutions are being made in terms of LTAC, SNF, et cetera, that those are appropriate and not harming patient outcomes?
I do not know enough about the US News ranking and their criteria to address that. This may be one thing in the late filing if we're allowed to, because I don't know if the criteria is physicians per population, it's primary care physicians per pop, is it specialists per pop? I don't have the metrics, so I'd just be guessing as to the basis that they use. Whereas I was very focused on metrics specific to post-acute. My guess would be it would be broader US News and World Support in terms of either primary care or care, but I don't know.
To drill down though, most of the analysis is based on kind of average utilization nationwide as compared to the utilization in state. Is there any evidence to which you would point regarding patient outcomes or, measurable patient outcome harm resulting from what you're describing as a lack of services?
I'm not aware of that data. What we do in other states is we actually go get patient examples and present that. We not pursue that here. So in terms of, is there an outcome metric? I'm not aware of one.
Can I chime in? So there's really, I think it's a great question, but there's really no way to know. For example, if a patient has some kind of event or medical condition and they wind up going to a skilled nursing facility instead of an IRF, It's possible they could get readmitted to the hospital and they could even die. There's no way to collect that data. So we don't really have good data to know how we can follow those outcomes on patients that maybe should have gone to an IRF, but they went to a SNF or they went home instead, and we don't really know what happened to them.
Rely more on like the physicians. There's one physician that talked about the need for it. So that's anecdotal. I recognize that, but piggyback on Dr. Sharpness statement.
Questions? Are the national reported differences that you've noted regarding potentially avoidable hospitalizations for IRF, SNF, and LTAC representative of the Connecticut experience? And if so, what evidence do you have to support those?
Did not look specific to readmission rates in Connecticut. And dig into that. And, late filing. No, I did not look at admission rate. I did, I guess, anecdotal, like Mary Wade, SNF wrote a letter. I looked into their quality of care, but that's one specific SNF, and you're talking broader. So need to look to that for late file.
Is there any evidence that you've come across where there's some sort of objectively right distribution of care between SNF, LTAC, IRF, or terms of number of beds?
I would look at the percent of utilization of those services, the discharge rate, but I don't have a metric that says for every acute care hospital, there's X number of IRF beds, and for every bed, there's X number of LTAC. That's what you're asking me, right? Like a ratio?
Essentially, yeah.
I do not have that information. I know that, in my opinion, when there's not enough of one type of bed is where we see that utilization rates that vary significantly. But I don't have that ratio that you're asking.
Put differently, how do we know that the state average for IRF utilization is better than what Connecticut currently has?
Ask me that.
How do we know that the state, so you provided some information about what the state average is, and you should, where the gap was in terms of where Connecticut is with access to IRF and where the rest of the country is. How do we know that the state, that average is better than what Connecticut currently has?
Yeah, that's a good question. And that's the fundamental difference in the physician and the intervener. And I would point to physician testimony is one. Again, it's somewhat anecdotal, but I would point to the significant disproportionate use of SNF and IRF, and that national average versus it is so different. Excuse me, that I do not believe it has the right number of IRF beds. And there is not data that I have seen that says Connecticut is so healthy they would not need an IRF bed. They never have a TBI, have a stroke. So I don't have the data to say Connecticut is different, does not need. Have is you've seen one in SNF utilization near the bottom and IRF utilization, and that gap is so significant. I feel like there's a need for.
So referring to that gap again, if all the states that you reference below the average were to come up to the average, wouldn't that necessarily raise the average of the country? So if you just forever be trying to chase the average?
It would be in that mathematically correct. And Rhode Island, for example, was one of the states that had that big gap in care, and it's closing that gap with Johnston. Then Oregon also had looked at additional beds. But yes, if the low utilization states increase, then the average would increase as well. And that has happened. And Danbury was filed, average was, I think, 12 discharges to IRF per thousand additional Medicare, and now it's 13. So one of my graphs shows that it's inching up some. Connecticut, again, is not. It's the outlier.
You're mentioning the gap in care, and then we're talking about the high end and the low ends. And then we're talking about now chasing tail with always trying to find then the mean. Have you looked at though the median Branford outliers then to find out where the true middle is?
I have not. I used the average in the graph, and then in the bed need, I actually used the 75th percentile, both in Danbury and here. Pulse of that, right? Because the median and the average are going to differ, and you have the outliers very high and very low. So this morning I was actually thinking about what would the weighted average look like, right? What would the population, looking at Texas and Florida as some high users compared to some of the northeastern states? And I have not done that. So I've looked at the average team. Then I have used the 75th percentile for the.
What do you think of, so everybody above the average? Do you agree that that represents overutilization of RF then?
No, I do not. I think that the average mathematically, you know, this is going to be because we have some states that are below and some states that are above. But the utilization of IRF is based on medically appropriate patients need that care. So patients have to qualify. Here can talk more about that, how they know that's the appropriate level of care. And then for Medicare Advantage, what we talked a lot about, and commercial payers, all the pre-authorization as well. So I would not expect that patients that do not need IRF in IRF. I don't know if Charbonneau wants to address that more or not.
Well, I mean, everybody knows that Medicare Advantage prior authorizations are an issue, not just in the rehab industry, but, you know, physicians who want to order for diagnostic tests for oncology patients. It's gotten a lot of attention in the press. And so I think, you know, that's a big ship to turn. I think we have seen enrollment in Medicare Advantage start to flatten, maybe because of that bad press. Doesn't mean though that the patients are getting what they need if they're denied Medicare Advantage. And that speaks to the pilot that that referenced, where we've decided in certain markets to, if we feel a patient really needs our services, we're going to admit that patient, and then we're going to fight it out with Medicare Advantage on the back end and kind of see how that goes. Not the first to do that, but it's just a way for us to kind of, you know, call their bluff, so to speak, because we feel strongly some of these patients that they won't give a prior authorization to are obviously very appropriate for our services. Medicare, straight Medicare? Reason that we know that Medicare patients are not being overutilized is because, first of all, the referrals that we get of Medicare patients, we only accept about 50% of them. And the reason why is because we have that very strict Medicare criteria that patients have to meet in order to get admitted to an IRF. And we're highly regulated. We get audits, we, we have a lot of experience with the different levels of Medicare auditors. So, we feel very strongly that we're doing the right thing for the patients and getting what they need, and we're getting them home in a timely fashion. And we've had good result when we do climb through that whole process up to the ALJ level.
I guess the reason I was asking Dr. Charbonneau to weigh in to make sure we're answering your question is that, so that means that just because you want, I say this respectfully, you want mama to go to IRF, doesn't mean that she can go to IRF if there's not an appropriate option to IRF. So that's why I'm comfortable looking at the data based on Encompass experience, that there's not overutilization of IRF in states that have higher than average.
One other example of that would be, I know there's been a lot of discussion about the TEAMS ACO, but of those diagnostic categories that are in TEAMS, joint replacement patients these days, you get your hip or your knee replaced, you're out the door. You don't need to come to inpatient rehab anymore. I mean, that's changed years ago. So, and I think that's why, as Matt was saying, we're not really worried about that effect on us, because again, it's from patients. It's not our patients anymore.
Attorney Rocha, I should have mentioned this earlier. If you want to do any follow-up, you can either hold that to the end or you can questions in the middle just for clarification, whichever you prefer.
Okay. I think I'll hold it to the end.
Still regarding need and duplication, but slight change in focus. In the Danbury application a few years ago, Encompass made an argument that CMS's implementation of a new payment system for SNFs called the Patient-Driven Payment Model, or PDPM, was expected to cause SNFs to reduce their therapy services and staff, resulting in an increased need for intensive rehab services. Your knowledge, has this occurred, and is there any direct supporting evidence that you can point us to?
From a global perspective, what happened initially with the change in payment system was that multiple skilled nursing facilities across the country laid off staffing short term. What I don't know is now that we are years past if that has leveled out or not. The ability of skilled nursing facilities to offer rehab is in group therapy. They have no requirements and they have group therapy, but I do not know the effect now in terms of direct correlation of that change in payment in inpatient rehab facility services. I just know that services continuing to grow, there's available beds.
Regarding emergency department boarding, has Encompass taken any specific steps to research whether Connecticut's ED boarding issue is tied directly to difficulties experienced with discharging to IRF level of care patients?
I have not done that. Know that getting the patients out of the general acute care bed quicker is going to free up that bed for the ED patient to move. But I have not seen any data available specific to patients are waiting on IRF or SNF.
We also admit patients directly from the ED. We have in some of our markets, we have liaisons actually staffing the emergency department for our patients. For example, an elderly patient that might fall with a pelvic fracture, can't really walk, they're in pain, have other medical issues, might be a very appropriate person to go directly to an IRF. They don't really need to be admitted. They're not going to have surgery. the acute care hospital.
And you know, when I talk to our hospital CEOs and they are meeting with the leadership team or case managers from the acute care hospitals, it is a regular topic of conversation. I know that doesn't answer your Connecticut specific question directly, but you know, anecdotally, it is a very, very commonly brought up concern from their part to get patients out of a med surge bed to the next appropriate level of care so they can free up that med surge bed for someone who's, you know, waiting in a hallway or waiting on a stretcher in the ED.
To the extent that patients are being admitted to a SNF instead of an IRF, then you would expect that the CHA report would focus on the SNF. Patients are not going to an IRF if need it, but going to a SNF instead to delay and to say it's an IRF that they, you know, but circling back to they're available and accessible. That's the right place.
I think just another example on the issue of throughput, which we recognize for our partners in acute care hospitals, it's a significant issue for them. We are able to provide a lot of medical care in our hospitals. You know, even looking back to the pandemic, we're helping our partners in acute care by treating COVID patients in our hospitals. We had COVID units and so forth so that they could have their more acute patients that needed to be in their hospital, you know, just help with that flow. And that's something that we continue to this day. And a lot of physicians who practice in acute care don't really realize that, you know, we can do IV antibiotics, we have wound nurses, we have respiratory therapists, we have, you know, we have in-house pharmacies, we do in-house dialysis. So we are really able to help the acute care hospitals move those patients to the next level if they no longer need.
I wanted to go back to your experience with Encompass Danbury. One of the charts, I think your Gooch presented, where it showed that utilization was exceeding what your projected amounts were for 6-7 months. Has any analysis been performed regarding what extent those were New York versus Connecticut patients during that facility?
By and large, they are from Connecticut. Majority of patients so far have been admitted to.
And Danbury Hospital, which is obviously located in Danbury, is our largest referral source. Have developed a great relationship with them, and but yeah, that's a majority of our patients are coming from that particular acute care hospital. But specific to patients from New York, get that information from a zip code analysis standpoint.
There's only a few
Very
patients. Now that you said that, we did talk about that, and it was 4 or 5. It was a very small number. Our position is-
Appreciate that.
Okay.
That's because our jurisdiction is Connecticut, so we typically stay within the bounds of the state. Let me just make a note. And if you can provide that chart, I think specifically with only the Connecticut, if there is some sort of difference, that would be helpful. If it's only like a few patients, then it probably doesn't make sense, but.
The census chart, like, you know, when you back out residents from New York, you're saying like what the census is, just looking at.
In term, against the projections and how it was exceeding the projections. But there are some things that I identified as we were going through that are just sort of late files. I'm not going to ask questions about them specifically, but one of them, Ms. Chafin, you said you would add LTAC to slide 6 of your presentation. So that's something that I wanted to flag and back to that later on. But I saw a little note here in my in my questions, but I want to flag that. Shifting focus again, still within the need category, but looking specifically at PSA methodology that was used here. So OHS asked Encompass to speak a little bit more about the methodology utilized to determine the PSA, and in response, Encompass mentioned a few things, including looking at roadways, traffic, and travel patterns. Did Encompass prepare any sort of internal analysis document that examines those factors in terms of travel distance and geographic, as to road flies distance and that sort of thing?
I would have used, as we all do, Google Maps early in the process, particularly in thinking about distance from, for example, Yale, New Haven down to Milford. So there would have been some travel time and distance I would have looked at. We also worked with someone in Connecticut that we worked with to make sure of the reasonableness of the patient service area and thinking about patient migration patterns and where patients will go and where residents go, where roadways and kind of the orientation of south during Lower River Valley. Is it going to come into Haven? Is it going to go to Hartford? Happens over with. Sorry, it is like you're going. Lawrence and Memorial, you know, I even considered going further over that way in River Valley, but in having discussions with people in Connecticut that worked with us, it was that we needed to focus the service areas we did.
So,
Some of it's kind of art and science, right?
well, so, and that's my question. So there's been a lot of focus today on the PSA. Lots of questions from this side of the room about the state or broader area, and the focus has been on the PSA. So is there an inclusion, exclusion, zip codes, or here's how we did it methodology that you have written out? Or is it kind of, let's look at whatever the mileage was, 20 miles, and then, well, that 20-mile border is a little close to that hospital, so we're going to move it over. Like, how did you do it? And is that written down somewhere that you could share?
Was in, God presume, it was in Zoom calls where proposed this service area by looking at some of the travel distances, having discussions with the folks in Connecticut, talking about the distance to Hartford. And I was very focused on even further southeast Connecticut River. So I don't have a work paper. I'll make sure. I don't have a work paper that said always do a 25-mile radius or always do a 30-mile radius. It really is going to vary by what's the population, what other providers are there, how is the patient flow, how is the traffic flow, what is the distance. Not answering your question because it was more about what's reasonable and what population is sufficient. We feel will also support that bed size.
And when you say thinking about factors like traffic flow or patient flow, what informed that versus just looking at a map and
Right.
saying, well, there's a hospital there, so they probably go there?
I may have some Medicare for service data. I need to see if it was that detailed. Let me think, hold on. I was able to look at rehab appropriate, RGs. What were the two counties then? Hanover and Middlesex counties, where those patients are getting care. Still don't know that that's answering your question. A lot of it was distance, so that I would not take a zip code further up in, for example, Lower Connecticut, near Middletown, that would be about equal distance from proposed project in Hartford. I don't think I have the both papers that you're looking for. Consider, I considered the size of the population, 65 plus. Also did look at the New Haven as my cutoff point. Makes sense because I didn't think anything southwest of that, those residents would travel to the proposed IRF. I felt like they would stay closer to home. That was the presence of an existing IRF closer. That was my cutoff geographically. Some of the zip codes in the city into the east. Still not a good, I don't have it's my 3 specific criteria and I weighted each one. What it's worth, the Danbury service area, looking at that and looking at the area and the expectation of where patients would go, it's been pretty spot on what we projected on the service area there. It's actually happening. Makes sense.
So Yale's IRU is in Milford. I think your PSA actually goes down to West Haven, which is one down over from New Haven. You have any specific recollection as to why Milford was excluded? Like why the cutoff point was West Haven instead of Milford?
Part of it is because of the proximity to IRF is a key criteria in how patients are choosing either IRF or SNF. There is an existence of Milford campus here. Did not feel like patients that far southwest would then be the target patient population to come to this proposed project. So let me say it a different way. If I'm a patient and I'm at Yale New Haven Hospital, I live closer to the Milford IRF, I do the proposed IRF, would expect based on the experience that I have working with Encompass that those patients would go to Milford. Meaning if a patient is discharged from Yale New Haven Hospital, it lives closer to the proposed IRF, would expect they would choose that facility in all things being to proximity.
A very basic question. I apologize for having to ask this, but are there any circumstances where a patient could be one of those patients that's eligible either for an LTAC or an IRF, where they could be referred out for both, and then like one of the facilities will just say, we'll take that patient, we can get them in sooner, or?
So from a referral standpoint, it's possible. Some hospitals will do blanket referrals and to say, hey, we have this patient, they need a bed. We're going to send this out in a referral system, and, those facilities or organizations will determine if the patient is rehab appropriate. But, through our education with the acute care hospitals, we do a pretty good job of helping them understand what inpatient rehabilitation is and how it differs from the others in the post-acute spectrum. So, I think most are informed, but it is sometimes, yes, we do get the same referrals. Certainly, IRFs and SNFs, typically will get a lot of the same referrals, and then, patient choice prevails and the patient decides where they want to go. Less common for us to get a referral, to IRF and LTAC, but, it has happened on occasion.
I was going to ask about patient choice, so that's helpful. Thank you.
Sorry, interruption. My client does have an answer for that as well, because that's what he does every day.
Okay.
That's helpful to you.
Sure. We can go a little bit out of order.
Yes, we see that on a regular basis. The acute care hospitals are looking to discharge patients, so without blanket referrals. And so we're able to take those, the most complex patients further in the state, even though they might be referred inappropriately to IRF as they've talked about. So that can happen. And we're, from a care of Connecticut residents, we look at how can we.
Thank you. Shifting focus now to quality and safety. So Dr. Chauvineau, I'm sorry if I'm pronouncing that wrong. Earlier you mentioned that Encompass had worked a little bit with Cerner to develop these reports or that informed some aspect of Encompass's operations. Do you recall buying that?
Predictive algorithms.
Correct.
Yes.
So in terms of how Encompass interacts with other providers in the area, I think most providers in Connecticut and probably nationally are Epic. Does Encompass have any, like, how does that work? Do you work with Epic as well, or?
So our hospitals are, our EMR is a Cerner-based or now Oracle-based EMR. However, we know that many of our acute care partners are on Epic, and it's not an issue. Our physicians have access, and our pharmacists have access to the Epic records at the acute care hospital, and so they can see the latest medications that were given, any other information. Also, we get a lot of information from the referring hospitals as well. And we just recently started a AI generated history that our physicians can use when they're admitting a patient, which basically uses I hate to get really nerdy about this topic, but it is AI. It uses a large language model to basically go through all of the documentation that we get from the acute care hospital and kind of, for lack of a better term, like summarizes it for the admission. That's been very well received so far. It's exciting.
Is that deployed nationwide at this point?
Yes.
Okay. Speaking with you for a moment, earlier you mentioned the readmission prediction model. And you also mentioned 2 other models that or initiatives that you had deployed within Encompass. But speaking specifically to the readmission prediction model, has that worked? Like, what has Encompass's experience been with that? What is the readmission rate prior to and after implementation of that model?
Yeah.
Speak a little bit to that, if you would.
Yeah, it's a little hard to know because we rely on claims data from Medicare and it's delayed. So don't have like we have no way of getting like patient level readmission data. However, we are partnering now with a hospitalist group that does telehealth in the home, and our high-risk patients we're having them seen with telehealth early if they're flagged as high-risk readmission, so that those physicians and their nurse practitioners can meet with the patient virtually and make sure that they're taking the right medication, if they start to feel unwell, they can intervene. And we've seen a 45% reduction in readmission for the patients that they're seeing compared to patients that they don't see. So that's pretty exciting. That's a relatively new project we've been working on. That's also kind of spreading throughout the country.
The CON criteria requires that an applicant demonstrate how a facility will improve the quality of healthcare services in a specific area. Has Encompass performed any analyses of quality and safety, same or similar services that it proposes to provide in Branford?
You're asking about like outcome data for specific skilled nursing facilities, for example.
Or LTACs or other area.
No, not beyond the, it was Mary Wade's skilled nursing facility that I take a look at because they had written just that they have, for example, the Red Hand air compare site, which is bringing about safety. That's anecdotal. It's not all skilled nursing, but I took a look at that only.
Looking at Danbury specifically, you have any insight into what Danbury's readmission rates look like? Danbury, Encompass Danbury.
Because Dr. Charbonneau mentioned, that most of that is, or up until now, since they have been limited to only accepting traditional Medicare patients because of the, getting the process of getting enrolled in the managed care and commercial plans. That would be all claims data-based information that we don't have current access to.
Sticking with Branford for a minute, what are Encompass's bed staffing ratios at its Danbury facility? And will they be the same in Branford?
So the nurse to patient ratio is between 6 to 7 nurses per patient day. So yes, we would fully, so we'd be consistent with how we've operated in Danbury and Branford as well. Which is, so we, across our portfolio of hospitals, we typically run between that, 5.9 to 6.1 or 6.2 nursing care hours per patient day. So there would be consistent across the state of Connecticut.
And is that consistent with the minimum required by federal and state standards, or is that above?
I'm not aware of federal staffing ratios, but we have worked at Danbury to agree upon a nurse to patient ratio that we are fully committed to adhering to, and we have been compliant with that agreement since inception.
And is that I think you just spoke to this. We talked about readmission rates for Danbury and how that's not really available yet. They don't have any post-discharge readmission rates or during stay readmission rates at this point either.
So I can access the, we call that acute care transfers. So there are patients that we admit back into we admit into our hospital who, they may have a, event unrelated to why they're coming to us. They get readmitted back into the hospital. I can pull that up momentarily and answer that question directly.
Be great. While you're doing that, I'll ask another question, which unfortunately, Mr. Gooch, you're probably the best equipped to answer as well. So if we need to come back to this, we can. So in the Danbury application, Encompass included a longitudinal comparison of functional independent measures. That's figure 6 in its application. It didn't look like this was provided, that was updated and provided as part of this application. Are you able to provide that same comparison for, say, the last 5 years that relied upon the uniform data system for medical rehabilitation, which Mr. Gooch, I saw you referenced earlier in your presentation, so I'm assuming you still have access to that.
Functional independence measure is no longer being used. Medicare decision. Those were what we call FIM scores, historically used for decades in rehab. And they wanted to have a functional measure that they felt could be used across different settings. So they transitioned to the, what's called the IRF-PI, Patient Rehabilitation Facility. Something.
Yeah.
yes, performance assessment instrument. And so now we have something else called GG scores, so we don't have FIM scores anymore, well, I wasn't there.
The year-to-date discharge to acute rate for Danbury is 4.7%, 4.76%.
Thank you. Want to ask some questions about access and potential impact on other providers now. Mr. Gooch, you mentioned Encompass, your CEO, I think you said, had recently had conversations with about a few weeks ago. Are you aware of what the outcome of those discussions were? What the additional discussions, or they came to some sort of?
Yeah, so I have the email. So the CEO did do a virtual introduction to myself and the individuals from Yale who he and his business development director have met with. They have asked for us to touch base with them, down the road closer to, if this is approved, they would love to find a way to, have a positive working relationship with us. We do task our leadership teams and teams to kind of go out and look for volume in secondary markets just to make sure that we are providing access to patients who need us in, markets that are outside of our PSA that can alleviate some of the length of stay constraints or challenges that we've talked about earlier. But I do have a follow-up email with those individuals, and I'm just waiting to get some times we can talk just very high level about, what we're looking to do in the Branford service area. They did commit if there were a patient that they got that happened to live closer to Danbury, that, they would make that referral though. I'm sorry, Danbury.
Okay. So, okay. That's helpful.
Yeah, and right, because proximity matters. But, I will say, I go back to the comment that they made that, they felt like the reason we should not expect more patient volume coming our way is because of that, geographical travel time that patients just don't, want to get rehab far away from their home.
You don't happen to know whether
Matt, you're talking about referrals to Danbury?
From Yale, correct. Because he had asked specifically about that question, that meeting that I referenced before. So yes, because of the travel time from Danbury to where their hospital is located, they did not feel that we would get a significant number of patients because they don't want to travel that far from that service area to Danbury, Connecticut.
Okay. Follow now. Thank you. Let's skip time. Well, I'll just answer. So OHS has routinely looked at recruitment and staffing as relating to our analyses regarding the impact on the financial strength of the healthcare system, as well as quality access, and whether there will be a negative impact on other providers. So what sort of information does Encompass track regarding recruitment of new employees for its facilities?
So information, so obviously we track retention. So when we do successfully recruit employees into our hospitals, whether they're new or existing, retention is a significant operational key performance indicator for us. So that is something we talk about and discuss regularly, making sure that we're giving our employees a great place to work and a place where they feel valued.
So I think what we heard earlier from testimony was to the extent patients have had to be turned away or there's been a waiting time for services, it's often been related to staffing shortages rather than space constraints or bed constraints. We're here talking about bed expansions. You described regarding recruitment that you would not come in and pay higher salaries to just take staff, but that staff have a right to choose where they work. But that's just a substitution of staff resources across space rather than expanding opportunities for treatment if we're not bringing in more staff. Because what we've heard today is that staff are what's limiting additional discharges rather than space and beds. So what opportunities are there? What experience or what data can you point to with your experience of increasing staff in the system and recruiting people from outside of just the narrow geography?
So we have a pretty robust tuition reimbursement program for staff. So, if you're a new grad nurse and you have a significant amount of student debt, we have a great, and same thing for therapists. We have, those type of things. We offer various like clinical ladder programs that will, reward people or recognize people for, their tenure and for taking on more responsibility and leadership. So, we feel all those things are nice. They are very attractive to prospective people who, might be new to the area or from the area that can, hopefully help, alleviate some of the staffing challenges. I will say, I think Lee was mentioned before, and again, I can only speak to our experience, but when the de novos or new hospitals that we have opened, we have not had to utilize, any contract labor. We've been able to find talent both from, the regional or national areas through our talent acquisition recruitment team.
One thing I'll just add to that is we do have a process now of following students when we have a fair number of therapy students and nursing students that come through our hospitals for rotations. And we now have a very good system of kind of tracking them and because they might not be ready right now, they're still in school. Or maybe they're going to school in Ohio, but they really want to work in Pennsylvania. We have a system of tracking them so we can keep in touch with them. So when they are ready and looking for employment, we can reach out to them.
And one thing that Encompass takes for granted is they do it, and it was addressed in the response to questions, is what Dr. Charbonneau was talking about. She may want to expand on this, is that stamps 512 through 529, there are a list of universities throughout the United States that those students can go anywhere. That goes to your pipeline, correct? Because they're not limited to Connecticut. One student would have to just go to a Connecticut facility. Correct, that's what you're talking about.
Yeah, so students that, are free to do electives in other places or get clinical exposure in other places, but when they're done with their education, want to go back where they live, or maybe not. Maybe they want to go somewhere else. And since we have a national footprint, it makes sense for us to kind of in touch with those folks and see if we have something that meets their needs when they're ready to look for a job.
So that the pipeline itself is growing and increasing so that it's not a finite staffing Encompass's perspective. It's not just trading the staff, it's trying to grow the pipeline.
The other thing is we have reimbursement. Let's say we hire a rehab tech, which is the lower level, just getting into like the nursing profession. We'll support them as they decide if they want to go back and get their bachelor's in nursing. And I mean, I can probably speak better to those, but we have folks that actually start as a rehab nursing tech and they wind up one day being a CNO with the company.
Keeping in touch and tracking people. Not to make it sound negative, but Do you track locations from where where you bring in other staffing? So like, are you aware of where most of the Barry staff came from?
I don't have that. I'm sure we have it somewhere. Our talent acquisition team probably has access to that. I'm sure we could follow up on that.
Well, we've got that off the record and we'll back to it, but we may request that. Um. no. Um, Shifting to costs and affordability. Don't have that many more questions for the applicant. As you may have heard, Connecticut has had some experiences with private equity that not great. I know that Encompass identified 23 private equity affiliations that its other facilities have in other states. Have there been any discussions that you're aware of regarding private equity entering Connecticut and buying their, either all of the Northeast region or Danbury specifically, or any element of that?
Not to my knowledge. I don't think that is going to be though anything. I mean, we're financially sound, positioned incredibly well. I don't anticipate that being something we would ever entertain.
You know why it was entertained in these other facilities though?
1 second.
I think this is, here's the completeness question.
That they highlighted as if this has been answered in the material.
Yeah. Right here.
Oh, the other one.
If you want to just point me to where this was answered, that's fine too.
Okay. Yep. I apologize. Yeah. The ones mentioned on page 3, question 7 were through acquisitions in the past. Yes.
And that question, I think, is answered in Bates label 491.
Relatedly, real estate investment trusts or REITs. Encompass mentioned that those were utilized in other states. But in this instance, Encompass's real estate entity is expected to be utilized here. What factors were considered in that decision?
Yes, I can get our real estate team to answer questions.
Just realize you're not on.
Yes, I'm not, I am a lawyer at the company, and oversee the SKU and program. So I help other information and put together a team to answer it. So we're happy to answer any of these questions through a late filing.
I'm just going to try under oath just to be safe, if that's okay. Raise your right hand. You solemnly swear, solemnly and sincerely affirm, as the case may be, that the evidence you shall give, or already given in this case, shall be the truth, the whole truth, and nothing but the truth. That's proactive too.
Yeah, absolutely.
That's the set you just gave, so thank you.
And answer any questions that aren't, I mean, if you want to let us know anything that was asked in the completeness questions that weren't addressed, I can get the appropriate people to answer those questions for you about the past acquisitions and relationships.
And so unless it's specifically asked for, we do not use REITs for de novo for new hospitals. So unless it was a joint venture situation, that would be not something that we would entertain.
So that's not being entertained in this instance.
That's correct.
That addresses that concern. So we talked about prices. Is Encompass able to make any commitments about the prices it will charge to commercial payers for its services in Connecticut over time.
So we have a managed care division that fosters and builds those relationships. So they'd be more appropriate to answer that methodology and how they what rates they come up with.
I did have a question about rates. When we had the slide earlier that compared the various types of providers. I think you all focused on the case reimbursement rather than the per day reimbursement. Are there any analyses of, similar patient and similar circumstances at the two? We've talked about the overlap of the LTACs and the IRFs. Similarly situated patient, is the argument that a similarly situated patient in an IRF is going to have a more rapid improvement and discharge, and therefore the overall cost is going to be lower? Or is this really a selection bias type of thing? We've talked about the LTACs have more severely sick patients. And so that's why they have longer lengths of stay and their total cost of an episode is higher, but their per day is lower. So if there's someone who's similarly situated that could get kind of similar treatment, we talked about the intensive therapy that they offer for certain patients. Would that be a similar cost across the two, or is it going to be higher at an IRF?
So looking at, from a cost per episode standpoint, we do statistically are able to admit patients comparing ourselves to nursing homes, which is a, more, apples to apples comparison from a patient acuity standpoint. Nationally, the data that access for the Northeast region, we're able to admit patients quicker, or we do admit patients quicker out of the acute care hospital, which means they're getting out of a higher cost of care setting and coming to us. And then when you look at our length of stay and our ability to get patients home versus sending them to another level of care post-discharge, and when you factor in our hospital readmission rate, that's why from a cost per episode standpoint, you factor all that in because of the intense personalized therapy that they get and our ability to get them home, that the episodic spend is less than other settings because of those, I would say, three factors.
Are you aware of any literature that, I'm thinking of something like propensity score matching, like similar patients in these different environments, what's the cost differential of the different settings? Because I think what was presented are some overall averages that are capturing a lot of different factors.
Your question, to make sure I'm understanding that, if Mrs. Jones goes to an IRF and Mrs. Jones goes to a LTAC, it's a difference in the charge. If it's the exact same patient,
Right.
the exact same diagnosis. I cannot speak to the LTAC, so I do not know how they would charge for a patient who would have a shorter length of stay than you. Just know what the would charge. I know that it would, the episode of care would be less. What I don't know, that's an LTAC question, is what would happen there? Would it be the 50,000? It'd be less. If it's an episode of care, the length of stay should not dictate charge. It's just not a per day basis, but it's more for an LTAC question. Are you with me? So if it's a case basis, which is how the reimbursement is, and I would think the same reimbursement.
You want me to answer?
We're talking in the middle, we're gonna answer some of these
I
questions.
think the next questions come to you all, so
Yeah.
same question.
Lori's like.
Oh, sorry, press pause.
If you have a response to that you think would be helpful. She was speaking to the IRF experience. If you have perspective from the outback, I think that'll be helpful.
Again, I think severity of illness, the overlapping, you can find data there. I can't speak to that specifically. George might be able to, because he wrote a paper on severity of illness 2, 3, whatnot. Also look at, so to try and answer your question as directly as possible, we talked about stroke patients in both settings overlapping. Some of our shortest, and again, we have to, now we're getting back into not all patients, but just Medicare patients. DRG for us, so length of stay for Medicare, average length of stay about 17 days. So that's pretty close to there, that IRF's average, and that's national averages, IRF's national average is about 14. They're probably pretty close in that. Again, we haven't done the data analysis, but if we're looking at, again, overall averages per day rates, we're probably going to be per day. That episodic care is going to be pretty, it's either close or we might be a little bit less. We'd have to actually look at that on that, but we've not done that specific analysis.
To be very clear, they're not paid per day. They are paid per case.
For Medicare.
Or
Yes.
That's right.
So thank you for the additional context. We can go to.
Redirect. Are you ready for redirect? Do you want a few minutes to gather your thoughts?
I have a list of late filings at the appropriate time.
We'll do that at the end, probably,
Okay.
unless you think there's some benefit to doing it now. But I think we're going to have late files for the intervener as well.
Okay. No, as long as we can do it.
Yeah, typically what I will do is I'll have a discussion. We'll figure out how long it might take to gather all the information, and then I'll issue like an order tomorrow.
No, this has been very productive, and I actually just have one question. Marty, at the beginning, the hearing officer referenced the US News article, and just as an aside, that is one of the ways I'm suggesting, if you can give us that citation and we can have an opportunity. But my question for you, in terms of patient outcome, the data that we've discussed today on returning to the community, the differences between SNRF, LTAC, isn't that a reflection of patient outcomes?
Yes, very much so. It's a strong indicator, and it shows that when you look at the percentage of patients that are returned to home, and this is Medicare fee for service, but that SNF has smaller percentage of patients that ultimately return to home. And IRF, LTAC, National has smaller percentage. In terms of Connecticut, Gaylord and Hospital for Special Care, a smaller percentage of patients returning home. And nationally, Encompass locally, we look at Johnston or Massachusetts hospitals. So there is a difference in outcome from that perspective. One moment. Sure.
Sure. And I think this is clear. In fact, Ms. Lyerly just asked me, is the record clear that there is no private equity in this? I think it is, but we want to make sure. So you're satisfied with that answer? Otherwise, we can respond.
No, I think we're good.
I think also there is, because you had asked about the FIM score, which we're not using, but we do have on the new, we call it a GG scale, motor recovery and ADL recovery. I think that's also reported on your Compare website. Share that with you.
That could be like.
Great. We're just gonna keep going. I don't have as many questions for interveners, so this, shouldn't take as much time. Um, So you testified about the difficulty of experience with recruitment and staffing. This, these first sets of questions are going to be directed to both of you. So I guess I'll go back and forth between having Gaylord answer and then hospital for special care and then so start with Gaylord first. Are you aware of whether any of your staff has gone directly from you to Encompass Danbury?
I'm sure of, I think too, and that's about an hour away.
And what positions were those?
Again, this is really digging in my memory banks to remember that. I apologize.
Same question for hospital for special care. Are you aware of whether any of your staff have gone to Encompass Danbury?
I am not aware.
So could we ask if those one or two live closer to Dan?
And I can't speak to the specific person at this point. I could go back and see if we can pull that information. I think that would be challenging the way that that right now. I can say that we in Connecticut, well, I saw one of my respiratory therapists when we were at HSC the other week. We end up sharing different people between the organizations, so it's fairly common for people.
You don't want that as a late file if possible.
Good, sure.
So now I'll start with hospital for special care. So as everyone has acknowledged, it's been 7 months since Encompass Danbury opened. Have you seen any changes in the types of patients you are receiving?
Well, that's hard to answer because of staffing concern. So we have had beds open on our rehab unit, so we definitely have capacity. Whether the referrals are not coming in, I know we've had capacity issues, so we've had to move.
So that's quantitative. In terms of qualitative, are you seeing different patients with different conditions?
Similar population that we've always treated.
Same question to Gaylord.
Yeah, 5% decrease in admissions from Danbury. I don't have the referral numbers in front of me. It's not, they weren't large numbers. We went down from 8.6 this year, year to date. And so and this was through March. Through then. It's an hour away. So it's never been a huge referral source for us. That's also why we didn't.
When you say Danbury, do you mean Danbury, the city?
Danbury Hospital.
Danbury Hospital, okay.
So assuming that they were diverted to Stanford. I have to tell that we're.
I'm sorry, are you talking about 8 patients to 6 patients? For what period of time? How does that go?
2 year March, so October 1 to.
Good morning. I think you mentioned that 2019 CMS has permitted LTACs to have IRF units within their facility. That correct?
That's true, but Lori actually said that.
Okay.
Okay.
I thought I read that somewhere in the document.
Great point.
I apologize. Are you able to explain how that works? Like what it involves? Is it just the repurposing of beds? Is it opening of a separate facility?
I believe the limited knowledge, because we have not looked into it because we didn't believe there was any. But I believe we would have to apply for, it would be a separate distinct unit under Medicare within the LTAC facility. So it wouldn't be, it would be a separate Medicare provider number, as I understand it.
Think geographic unit. Well,
Yes.
we did it before, so you need a distinct area. You can't lean between the two. It needs to be this number of 12 beds or whatever it may be. Would be designated within our hospital.
It couldn't be shared beds that you already have under Medicare certification. So it would be a separate distinct unit.
That requires separate licensure? Or would it remain LTAC, just sort of categorized differently?
That I don't know, under the state of Connecticut. I don't think anybody has ever, just two of us have ever looked into it. But again, because we can treat some of these patients under our current long-term acute care hospital nation, we have never believed that there was a need to talk to things.
If you were to explore that further, do you have any idea of how much it might cost to repurpose things and reorganize?
Sure, it would be very costly, because we would have to have space. Designated unit, and right now we don't have space for that. Be a lot of planning that would have to go into that.
Have to read it, designate beds, that's the like meeting. That's what you get away from the rural healthcare system.
Yeah, the other area is that because we can admit some of the IRF patients under that IPPS, the short stay designation, that kind of negated the need for us to have to look.
So you mentioned sort of there's been like an informal analysis or assessment. You've determined that that hasn't been needed. Was there any formal assessment that was conducted and put in writing or anything to that effect?
There wasn't, because we always had beds, so there was no need to even spend the time or focus our energy on looking at that.
Our initial analysis, because of the geographic separate unit, as everybody knows, to try and keep your occupancy up, there's that little delta on the beds. We'd actually end up with having two deltas. Our census would be lower, hoping potentially to stay less. And that's why we saw our referral sources, ask for the spaces. So.
Can I just follow up with those IPPS cases? They are not paid, just to be clear, at that LTAC 50,000, a much lower rate for those patients. So when we look at the data that was showing the average length of stay of 25 days, those patients don't stay that long. That's not the payment that we receive for those cases.
Encompass testified to their salaries being competitive, not like super high in order to draw people in. Have either of you done any sort of market analyses to determine whether your salaries are competitive?
That's what I had. Sure. We use the CHA data. So every year we do a market analysis and an interim year. So we do it essentially twice a year as how we look at a full annual one and then an interim basis. So to make sure where we stand with the Connecticut marketplace with all, say, nurses, but it's really full of all different job classes and roles. But, nursing's an example where we'll look and see average. We all pool our information into that.
Does that look at,
And then obviously make market adjustments. The reason we're doing that is to make market adjustments, to stay competitive. Because if you're low in a competitive environment like this, people go, and trust me, we hear about it. Everybody talks about salary now. So like it's an open secret. For everybody doing. So they share that information and staff.
We also use, we rely on the CHA data, but we also have another third party system that we also use to look at salary wage data for market purposes. The one thing that we have to also take into consideration is within the state of Connecticut, the geographic areas where we are in the hospital for special care in New Britain is very different than downstate. They pay higher wages downstate because they're closer to New York. And with Medicare, they factor wage and labor rates into the Medicare cost report. So, when you look at that competitive data, you have to also take that into consideration.
Hearing officer, Attorney Roca mentioned point file. I think it would be very helpful in this case for the applicant to provide its salary data ranges for rehabilitation nurses. Looking at Dr. Charbonneau's testimony, occupational therapy, physical therapy, speech therapy, and respiratory therapists that are key to rehabilitation, as you see, including the of scholarship programs, which in forgiveness programs. Be helpful to see that data, to see if there is a character if the applicant is above raising a compliance issue. But the nonprofit rehabilitation sector is able to pay. I think illuminating both on the agency in terms of, as has been talked about, staffing is at a premium. The healthcare continuum, so we request that.
I am concerned that raises some anti-competitive concerns. So I don't think that we
To the agency. Just throwing it out there.
I don't feel comfortable asking for that. I appreciate that, but I don't think that's integral to our process. It's a little relevant, but lost track of where I was. I apologize. So the next set of questions are going to be for Gaylord specifically. So, yeah, I was saying the next 41. So you referenced losing some patients to Harvard Healthcare after it opened IRU in 2018. And you described the amount of that loss. Are you able to describe the sorts of patients that lost to Harvard Healthcare?
So this data is directly from Harvard Hospital. So this is the this is the admissions from Harvard Hospital during that period of time. So that's what that graphic on page 5 shows. So we had a distinct decrease in admissions after Hartford Hospital opened their IRU.
And what types of patients though?
So those are patients that we would normally see. So we have an overall census, it's actually page 8, sorry. So those would be across a gamut of, it's an aggregate. That's the best way I can answer it.
Yeah, you probably wouldn't have that information now that I'm thinking about it because I don't Harvard Healthcare. Are you able to articulate whether there has been a detrimental impact on patients that resulted from the loss of patients going from or LTAC and instead going to the IRU?
A challenging answer because we don't know. So I don't know if I could speak to them.
You spoke in your pre-file about the Yukon residency program offered at Gaylord, and you referenced the possibility that Encompass Branford could cause the program to fall below the required case volume thresholds, threatening accreditation. What accreditation was that in reference to?
So I mean, even in our residencies, the ACGM. Thank you.
And what are the case volume threshold?
So it's both, it's one rotation is spinal cord injury, one rotation is brain injury. We did average at an 8 for 8 per for the length of the 3-month rotation. So it can go up and down, but your average needs to be 8. That makes sense.
Turning to hospital for special care. There's been a lot of talk about team hospitals and their assumption of risk in 2027. Why will implementation of this new team change result in them being incentivized to keep care within their system? Don't they already have that incentive?
Not the acute care hospitals, not Yale, and they have to, for the 30-day bundled payment, when a patient gets discharged, they're responsible for the care 30 days after. So wherever that patient goes, it's part of Yale's new payment that they will receive. So it's not currently in, the payment system hasn't started yet. We have talked about that. It's in effect for the first year. So in year 2, Yale will be responsible. So they will be more apt to keep those patients within their system and not send them out because they are going to get old.
Officer, for the record, I object to that comment for Ms. Rudden. Gail may not do.
On the basis of speculation.
Foundation speculation, yes.
Take it for what it is, but yes, you can't speak on their behalf. I'm not going to give it very much evidentiary weight.
That's what we see, just so that you understand, that's what we see with Hartford Hospital as well. Hartford Hospital is on every street corner in the state of Connecticut. And they are in various different physician practices, all sorts of different service lines, and they keep it within their own house. That's how they make money.
Again, for the record, I would.
Any more questions? So you point to the March 2025 MedPAC report to Congress as a basis for concluding that there is sufficient LTAC capacity to meet demand. There's been a lot of focus on national information versus Connecticut information. Isn't that report based on national data rather than Connecticut specific data?
Yes, I believe the MedPAC data is national, but it references, if I recall correctly, I don't have my notes in front of me, it references IRF capacity. It's not LTAC capacity, it's IRF capacity, which they said was sufficient. And that's nationally.
And you mentioned you've at times had to halt admissions and limit your inpatient census because of staffing constraints. Are you able to tell us how many times you've had to do that and for how long?
I do not have that data with me. I'd be more than happy to pull it together in a late filing. But I know that we have had quite a few conversations with the state of Connecticut, Department of Social Services and OPM in regards to that, because the state views that as a serious concern from their perspective, because a lot of these are the Medicaid patients that, us being 80% Medicaid, their concern is that they personally have gotten calls from acute care hospitals that we have stopped admissions, so it has risen to the point of the state being concerned. So we've been tracking that.
Have any other? All right, I think we're done with our questions. I do want to take, hard to do this, but maybe like a 10-minute break just for us to organize our thoughts around the late files, and then we'll come back and speak. And then we will do closing arguments, which again are limited to 5 minutes each. So we will come back at 6:15 and hopefully wrap up a little bit after 6:30.